Hi everyone, we're here to discuss patient Sheet Aloda, the 73-year-old female with history of falls. Now she's living alone in a 6,500 square foot, 2-story home. Her husband just passed away, and she's a socialite and volunteers her time working with older folks with disabilities. She has a diagnosis of supranuclear palsy, which is rapidly progressing. Comorbidities include hypertension, AFib, and diabetes, all of which are controlled with medication. She has one son who is a lawyer in Midtown Manhattan. Aloda has been in a SNF for the last 8 weeks following a qualifying hospital stay at Yale New Haven Hospital. Her progress has plateaued. She needs an assistive device to ambulate. She is Min-Assist to transfer to and from all surfaces. She has the option of staying in the SNF. However, she is a very proud and wealthy woman. She thinks that she's above living in a SNF, bearing in mind that all the residents in the SNF are very wealthy individuals. This is a continuum care facility with an assisted living section and an independent living section. She declined the offer to live in the move into whatever, where she would be provided assistance 24 hours a day as needed. It was explained to her that in order to be discharged, there would need to be 24-hour assistance. She agreed and hired a home health aide a week after being discharged. She fired the aide and was seen ambulating around the community without a walker. She had a terrible fall, resulting in another qualifying hospital stay at Danbury Hospital. She was back in the SNF after only 2 weeks of being discharged to independent living with an aide. In a conversation with the social worker upon readmission, she stated she was much too beautiful and ladylike to be walking with a walker. Additionally, she did not think she needed an aide and was quite capable of taking care of herself. Given the circumstances, she was no longer safe to be discharged home without guarantee that she would have 24-hour care. Her memory is quickly declining, as is her speech. As long as she's paying her bills, the facility could not legally force her to vacate her apartment. So PT, do you have any opinion on this?
Given Aloda's diagnosis, PT's not likely to help her. She has difficulty with sit to stand and also has a Parkinsonian gait, and she has difficulty initiating ambulation. We did get her a U-step, which has been on trial to her for about 2 weeks now. The only problem is that they're not covered by her insurance. She's refusing to pay for one, and they cost about $800. So we need to come up with some sort of solution as far as her getting a U-step to send her home first. Also, we've conducted a home eval, and all the recommendations are in place, but the main recommendation is that for her to be discharged, she needs 24-hour care. And on our end, if PT can't help her and she wants to be discharged, she needs this. So,
Occupational therapist.
Well, she's not very compliant with using her adaptive equipment, and she's going to need help because her cognition is declining. She's going to need help with medication management, so we're definitely recommending 24-hour care as well.
Speech therapy, any thoughts?
Well, you know, as we said before, her mental status is declining. She's giving certainly very interesting rationales for refusing to use her ambulation device and for also dismissing her home health aide. Specifically from a speech therapy perspective, her ability to communicate is dissipating. That's only going to continue, and that's going to be followed by her ability to form complex and then basic words and even simple sounds after that. We can prescribe her medication that's going to slow this process, but ultimately if we're going to really work at preventing this from happening, we're going to need to get her someone there as long as possible that can engage her in conversation and continue to work her in this way. So like I said, we'll go ahead and prescribe the medication, but she's going to need someone there to help her at all times.
Nursing.
She has been compliant with taking all her medications for her blood pressure, AFib, and diabetes, and her vitals and blood sugar have all been normal. She has required minimal assistance transferring from most of her services, and that sometimes increases to a moderate assistance, especially from transferring into her bed at night. So I definitely recommend that she stays at the SNF until she can get a home health aide to be with her 24 hours, help her with those transfers.
Dietitian, any?
So she continues to maintain a healthy appetite. She's eating all her meals. So at this time, I really don't have any concerns from my end as far as that goes.
Okay. Social worker?
Before falling ill, Aloda was very active in our church community. So I've invited her pastor to come speak with her he has any recommendations for her. As at this time now, I'm also going to schedule a meeting with for her son to come visit her. We're going to talk about it. We're going to schedule a discharge plan, see a plan of care, see if she's willing to move back to SNF, or where we're going to take her from there.
Physician.
This pathology, once it starts rapidly progressing, there's not much we can do to kind of slow it down, unfortunately. We're going to try to adjust some of our medications, maybe try her on some new medications, see if we can kind of slow that progression, but I agree that we should keep her in the SNF as long as we can.
Any last words, PTOT?
Yeah, well, like we said before, it's really not an option for her to go home by herself. I know she thinks that, with the kind of lifestyle she has and how she perceives herself, she is really above that, but she's going to need more help than she actually thinks she needs. So I don't think she's in a position right now to make decisions for herself, so getting her son in is going to be a good idea. But she definitely requires an aide at home if she wants to go home. Otherwise, definitely a SNF is a good placement for her.
Yeah, I agree with Tony, our OT. She does need 24-hour care. Also, we need to look into possibly finding a way to get this U-step for her, which could also be very beneficial for us in discharging her. But 24-hour care is the main issue right now, and I think that everybody else is in agreement with that.
Yep.
All right, then we'll try to set up some managed care for next week. Does that sound good?
A care plan meeting, yeah.
Sounds good. Yep.
All right. All right, that's our last patient, guys. You guys are free to go.
What the heck? Are you serious? Oh my god. Oh my gosh.